induce a electrical activity throughout the heart. Okay.
Yeah.
And so we're gonna have we can have a premature junction contraction, junction escape beats, accelerated junction rhythm, junction tachycardia, Wolff-Parkinson-White Syndrome, which what we're interested in, and the paroxysmal supraventricular tachycardia. All right. All of this, the problem is at the AV node. So in this case, the premature junctional contraction, what do you think is going to happen in this one?
It's going to contract prematurely.
Right.
So what is it? What in this case? What does it use as a pacemaker cells? Because if it's contracting prematurely, is the signal still originally coming from the SVN, or I mean from the SAN?
Yes. In this case, yes. That is correct. But just take a look at what we're going to have here. Okay. So let's look at the first example. We see here on this first one that there's a P wave for a QRS.
Uh-huh.
There is a P wave, a little bit different for the QRS.
Mm-hmm.
And then there's a completely different one for this QRS. It's upside down. Okay.
Okay.
In this one, we also see it's a bit different. Like they're not perfect, but they're still very, very alike. This one and that one, for example.
Mm-hmm.
Okay. So let's look at what it says here. It's initiated at the AV node. It takes over the pacing when it's not required to. So in other words, the SA node is working, right?
Mm-hmm.
And the P wave itself may be retrograde, as we saw the first example. Okay.
Mm-hmm.
So that is a characteristic premature junctional contraction when you have an inverted P wave. Now here's the problem. The P wave may show as it's showing here when it's before. It can show as a negative. It can be retrograde. It can be during, as we see on the second example.
Mm-hmm.
How do we know that? Because on every single prior and after, we see a P wave for every QRS. But then on this particular one, there is no P wave. That means that AV node contracted within the QRS. And that's why you see the P wave in the QRS. Okay?
Okay.
Hard to detect. You cannot see the P wave. But you know it's there because something induced the QRS to contract.
Right.
And the QRS, it's normal, right? The ventricles are not affected. Mm-hmm. There's nothing different from here to that. That's how we know that it's a P wave inside the QRS.
Mm-hmm.
Right?
Mm-hmm.
And in this last case, we see here that there is a P wave after the QRS.
Oh, that's interesting. Yeah.
The other ones are different, but this one is not. Sorry, the other ones are all the same, and this one's different. All right?
Mm-hmm.
And remember, the Qrs morphology, in all of them, they're very narrow. So the ventricle is not a problem. All right?
Mm-hmm.
And on this, there's an image here on the right where it says the NH. I cannot remember what it stands for, but that is the susceptible area where it's not working properly.
Okay.
Here's the atrial node. There's the N node. There's here it tells you where the left bundle branch is going to be located, the right bundle branch, but it's like the neck location of the junction between the atria and the ventricle. All right.
Mm-hmm.
All right. So here's the next scenario, a little different. In this case, this is like a compensation that is happening, and it's called the junctional escape beat rhythm. Okay.
Uh-huh.
And so in this case, we know that normally the AV node fails to pace because there's the overdrive suppression. But in this case, there's going to be protective pacing that occurs by the AV node when there's no detection of the SA node. Does that make sense?
Mm-hmm.
So let's look at the example here. we see the first QRS complex that is normal. It comes up with a P wave. The second one comes with a P wave. The third one comes with a P wave. And here we have nothing. It's longer. We don't see anything. Okay. Then we see one quick P wave that is very attached to the QRS and induces a contraction on the heart. Then we look at it again and it's back to normal. That is a Johnson escape beat. How do we know that? The P wave is closer.
Okay.
All right. Take a look at the other ones. They're all the same length. Okay. All right. So it says here that you may have a retroactive P wave that may be present. Again, it can occur before, during, or after. As we see here on the second one, this is way more easier to take a look at because we see that there is, for this characteristic ECG, we see a P wave that is normal for the QRS, same again. And look at that, the long SA node. I says here right here, the SA node gives up. It forgot to send a message. The AV node detects it. And sorry, in this case, I apologize. In this case, the AC node did recover because we have the same morphology of the P wave. But then again, it forgot. Look, it forgot to pace again. And now in this case, we see a junction escape. How do we know that? The P wave is different. In this case, actually, we don't really see the P wave. It may be inside the QRS. Okay.
Right. Wow. Okay. That's interesting.
Yeah. And in this last one, we actually have a junctional rhythm. How do we know that? The P wave is inverted in all of them, and it's rhythmic, meaning there's no variation between each beat.
What does the inversion of the P wave mean?
Sorry?
What does the inversion of the P wave mean?
Well, think about it. The inversion of the P wave. What should it mean, the P wave?
Well, the P wave is a contraction of the atrium.
Right. And if you look at the wave of the electroactivity goes from top to bottom. So if we see an inverted one, it will be what?
From bottom to top.
Exactly.
Oh, right? So that means that the SA node, that the AV node is the one supplying the power.
Exactly. Yes.
Because it's going away.
In this case, absolutely. There's no SA node responsible in this case. In this case, AV node took over.
Okay, so that's like a protection. That's like a fail-safe.
Compensated. Exactly. Protective.
Okay, that's interesting.
Right. Yes. All right, so now take a look at this one. This is just, I apologize. In this case, when you see the junctional escape beats, this may occur in bradycardia. All right. So when the rate is between 35 and 60 beats per minute, this can occur. Okay.
Okay.
So in this case, there's going to be accelerated junctional rhythm. So that just means that the rate is going to be between 60 and 100 beats per minute.
Okay, so normal.
Exactly, normal. And how do we detect that? No P wave whatsoever. If you see it here, there are no P wave for every QRS.
And that's because the SA node isn't working and the AV node is taking over.
Yes, and look what it says here.
Oh, P wave inside the QRS complex. Okay.
Exactly. How do we know that? The QRS has a normal, narrow duration. All right.
Wait, so then what does that mean though? Like, okay, what does that mean from the mechanical functioning of the heart? So you're having, if the P wave is inside the QRS complex, then that means that you're having the depolarization happening at the same time, which means that you're having contraction of the atrium and the ventricles at the same time?
Yes, pretty much. But well, it depends. Well, the AV node, if it shows before, then it's happening before the QRS complex kicks in. All right.
Mm-hmm.
If it happens after, you'll see it like this. See that?
Mm-hmm.
So it depends. It's all about the timing in this case.
Okay.
All right. So, sorry, I apologize. I think I said it. It will always be inside the QRS. That's not the case. You could have it. The only difference here is that the ray is different. That's the only difference.
Right.
That's the only difference. So accelerated junctional rhythm. The name says it all. Then we have junctional tachycardia, which is 100 to 140.
Mm-hmm.
The name gives it away. It's the same as tachycardia, right? Anything above 100.
Mm-hmm.
But in this case, there are two types. You have the one that has with AV dissociation and without AV dissociation. And that just means that you're going to have different morphologies for all the P waves. So if you take a look here there's no P wave, so it's inside. This one repeats. This one repeats. Here we see a premature P wave. Here we see another P wave that is different from this one. And here you see another one, and here you see another one, and here you see another one, but the pure interval is longer. Okay?
Mm-hmm.
So it says right here that the atrial activity from the AV node is not coming up. So the atria starts to pace itself. All right?
Mm-hmm.
The PR interval changes, and this is the dissociation. The PR interval dissociated because you don't see any rhythmic interval that keeps being consistent. Okay.
Okay.
Compared to this case where we see that there's tachycardia, but there's no AV dissociation. All right.
Mm-hmm.
So they all depolarize with a regular timing between them. So in this case, they all have the same. The P wave comes after every single time you see it inside the T wave.
Okay.
All right. All right. So now Wolff-Parkinson-White Syndrome. This is the big one. If there's something you want to know, it's actually absolutely this. All right.
Yeah.
So what do we have here? I wrote down here the bundle of Kent, referring to an accessory pathway that breaches the annulus fibrosus. So there's a pre-excitation syndrome. So there's some anatomically that is, and congenital too, that gives you an accessory pathway inducing a like an ectopic beat, like we talked the other day, right? Remember that?
Mm-hmm.
And so this thing is gonna bypass the AV node from the atria straight to the ventricle. Okay.
Mm-hmm.
And the reason why, and the way it's gonna represent in the ECG is with a delta wave presentation. And that is just the little mountain here that goes from between the PR interval, jumps into the QRS. You're going to have a broad QRS complex. That is also going to be characteristic. And here's my drawing that I did here. This is the QRS. Sorry, this is the heart. This little square. It looks like a window. The right atria is here, where the SA node originates. And you see that it normally goes through the middle, right? To then polarize within the bundle of His. But in this case, there's an accessory pathway. So this one's going to come from the side and depolarize.
So it skips the bundle of His. Does it skip? Well, I guess, yeah. Does it skip
Exactly.
the AV node?
Exactly. It skips the bundle of His.
Does it skip the AV node?
Yes, it does. Bypass the AV node.
Okay, so it doesn't even hit the AV node or the bundle of His. It just does the bundle of Kent.
It has created its own pathway
through the right ventricle.
You could have, in this case, we did it through the right ventricle, there's an annulus fibrosis that allows, because dead tissue, it allows for an ectopic beat to occur, and so electrical activity can go through there.
Okay.
Okay, so we're gonna see a short PR interval, the delta wave and broad QRS that I talked to you about. And it says here that the ST and T wave changes are also going to be occurring due to the altered repolarization. It may mimic a left ventricular hypertrophy or a right ventricular hypertrophy. So it depends where the accessory pathway is. Okay?
Okay.
All right. It says here that procainamide is the treatment, and 3 in 1,000 people have it. The Marcus Ulrich from the San Antonio Spurs was diagnosed with this, and he retired because he was feeling some sort of pain. I don't know if you know him.
No. Wait, who was it? What's his name?
LaMarcus Ulrich?
No.
No? Okay. All right. So, again, delta P wave. Sorry, delta wave. Very important. You see the short PR interval due to that delta wave. And look, very easy pathway here. Easy to recognize, right?
Mm-hmm.
It has made a parallel pathway allowing the electrical impulse to occur. All right?
Mm-hmm.
It comes from the sinus. It's a sinus impulse, but it comes from here, right? And that is what is causing the problem.
Oh, that's interesting.
Yeah. And it's an upstroke that reflects the accessory pathway through that delta wave. Okay.
Okay.
So here it tells you that the way you can recognize in DCG is like this. Because the V1 is it's looking at the right ventricle, sorry, the right atria and the right ventricle. It's in that area. You're gonna see it being having a positive or a biphasic left-sided pathway. Remember we talked about this?
Mm-hmm.
If it becomes biphasic, it means it's gonna be the electrical activity is gonna be shifted.
Mm-hmm.
Well, in this case, that's what we have. The QRS is going to be positive or biphasic if it happens on the left side. Okay, so if it's on the left side.
Okay.
If it's on the right side, you see that you see the little accessory pathway connected here and here.
Mm-hmm.
If it's on the right side, you're going to have a negative deflection on the V1. Okay,
Oh, the delta wave would change.
the delta wave would change.
Okay.
So depending where it is.
That's cool. Yeah.
This is the most characteristic one. This one, delta wave, is the most frequent one. And here's the annulus fibrosis that we see.
So this is an anatomical defect then?
Yes. Yeah.
Okay.
And the ventricle tissue extends all the way up. Here's the left ventricular chamber. And here we see accessory pathway. Take a look. This is a beautiful diagram where it shows the flow, okay?
Mm-hmm.
That would take. All right?
Mm-hmm.
All right. So it says here that sometimes you can see a maximal pre-excitation. So the accessory conduction is going to be faster than the AV node route. So it's going to be an all delta wave. See that? This is an all entire delta wave.
Mm-hmm.
Short PR with a long or broad QRS. When you see that, consider for a Wolff-Parkinson-White Syndrome. Okay.
Mm-hmm.
It's actually very easy to recognize because it's just a little bump. And where's our? What do we see here in this case? This one, I don't really see anyone here. Like, oh, this is the delta wave. That's the delta wave right here. Very broad. It's usually just 2 squares. This one has more than 4. All right.
Mm-hmm.
And it's characteristic as well because you see the T wave upside down. So what if it's less than maximal pre-excitation? So that's a fusion beat. And this is what it's seen more often. The polarizers from accessory pathway and the heavy node. So in this case, we see the delta wave. Delta wave right there. It's very tiny, but you see a little jump. This one is big. This one's nicer. Okay, they all have a little bump. No, I don't see it there. I do see it here. Take a look at this one. Very characteristic, right?
Yes.
Compared to the other ones. Look.
Yes, of course.
Nice and smooth. This one has like a concave.
Oh, so it's not going to happen at every beat?
No. It's not going to happen at every beat.
Okay.
So.
But you could see it at every beat according to your notes.
You could have it, but look what it says here. It occurs when there's a long refractory period. So when it's not repolarizing right away, that's when you're going to see it. So it depends on the refractory state of accessory pathway. You may see it on every heartbeat. So it depends. So in this case, like we see here, 1, 2, 3, we have one. 1, 2, 3, we have one. So this one has a long refractory period conducting every third beat. Does that make sense?
Mm-hmm.
Okay. Okay, and so I think that is the main thing about Wolff-Parkinson-White syndrome. This, I do remember this being a bit challenging, but we can take a look at it. It says that there's the orthodromic tachycardia and antidromic tachycardia. You're going to have a narrow Qrs complex on this one. And on this one, you're going to have a broad Qrs complex, which is the one that is more recognizable and more frequent as well. All right. So what does that mean? That just means that the propagation through the ventricle will be slower. Okay.
Mm-hmm.
And you see here you see the heavy node, and that's the accessory pathway. All right.
Okay.
And I just want to, this may be important. It says here that the accessory pathway provides a route to set up a re-entry circuit and use the ventricles that is independent of the normal pacing in the AC node.
Okay.
Yeah. So here we see ventricular tachycardia.
Wow.
Atrial fibrillation, Wolff-Parkinson-White syndrome with accessory pathway. Atrial fibrillation with 2 accessory pathways.
So a person could have 2 accessory pathways.
Yeah, in this case, very unusual, but it could happen. All right.
Okay.
And the last one is just paroxysmal supraventricular tachycardia. It starts and stops suddenly with no warning. So that's what it pretty much means. So circus movement tachycardia. Again, it can be Wolff-Parkinson-White syndrome. You could see it. You could see this where you see a normal morphology with a patient with Wolff-Parkinson-White syndrome. Atria and ventricles activating sequence. The P wave is distinct from QRS. Initiating PR interval not prolonged. Okay. So that is a key feature for the circular movement for Wolff-Parkinson-White syndrome. Let's see what it looks like. So let's take a look. Let's take a look at this. we start with the normal QRS, tiny delta wave, hard to see. Here we see a T wave, here we see a P wave, and here we don't see a T. Oh, I mean, we do see a T, but we see a P within the T because a QRS complex occurs. All right?
Okay.
And it says here that this ectopic changes the heartbeat. This ectopic induces the setup for tachycardia. How do we know there's tachycardia? Because here we see the R to R it's
lighter, yeah,
lengthy,
longer, yeah.
And then here it sets up. This is shorter because the ectopic came here, and then we have the persistent QRX complex being altered. All right.
Mm-hmm.
All right. And not important, the AV node reentry tachycardia without accessory pathway uses existing pathway. So again, this is very, very characteristic. You don't need to know this. You also do not need to know this. All right, are within the shuttle by QRS and supraventricular tachycardias occurring in the AV node. We've seen that there's a junctional tachycardia, the paroxysmal SVT. There are two types, and that will be all. Right. So again, like I told you, the other day, the main thing for Wolff-Parkinson-White syndrome is the delta wave with a short PR interval. Okay.
Mm-hmm.
Where is it? This one. That's the characteristic one. All right.
Mm-hmm.
Especially here. Where is it?
Is that the only condition that will demonstrate a delta wave?
Yes, for sure.
Okay.
Delta wave is unique for the Wolff-Parkinson-White syndrome.
Okay.
Yeah. And tomorrow, if we do it tomorrow, then we're gonna discuss the first degree AV block, second degree AV block, and third degree AV block. Those are we need to know.
Yes, I agree with
and this is well explained. You're gonna understand it, right?
Okay.
So main takeaway for Wolff-Parkinson-White syndrome:
delta waves.
And why does it cause?
Accessory pathways, either right or left.
Exactly.
If it's right, you're going to see the delta wave going up. If it's left, you're going to see the delta wave going down. Right is more common.
No, the left is more common.
Oh, the left is more common?
Yes.
Oh, I'm sorry. Left, you're going to see it going up, and down, you're going to see it going. Yes, left, you're going to see it going up, and right, you're going to see it going down.
Yeah.
And left is more common.
Exactly.